afternoon, everyone. My name is Benita Rodman Jenkins. My pronouns are she, her, hers, and I direct the Spiker Rubin Women's Center for Equity and Diversity here at NJCU. I am also the president of BASO, which is the Black Alumni Administrator, Faculty, Student, and Staff Organization. I also coordinate our Gothic Night Ally Safe Zone program, and I am so excited to welcome each and every one of you to today's program, Eliminating Racial Disparities in Maternal and Infant Mortality. It is my pleasure now to introduce someone who is known throughout the state for initiatives focused on infant and maternal health, climate change education, and fostering women-owned businesses. Welcome with me, the First Lady of the state of New Jersey, Tammy Murphy.
Good afternoon, everyone. Benita, thank you so much for that introduction and for your leadership at the Spiker Rubin Women's Center for Equity and Diversity. I'd also like to thank Sue Henderson, president of New Jersey City University, for the invitation to speak today. So much of my work through Nurture NJ, as I will elaborate on in the next few moments, is about partnership and collaboration. And I am so proud to count NJCU and all the speakers on this panel as partners to Nurture NJ. Our missions all overlap, and raising awareness with respect to New Jersey's maternal and infant health crisis has been one of the most important parts of our initiative. Once aware of this issue, people are immediately motivated to work together with us. So I thank you all for your incredibly important and powerful advocacy. I would like to begin with the overarching facts surrounding the current landscape of maternal health. The United States is ranked 55th in the world for maternal deaths. New Jersey is ranked 47th in the nation. And our racial disparities are even worse. In New Jersey, a Black mother is 7 times more likely than a white mother to die from maternity-related complications. And a Black baby is over 3 times more likely than a white baby to die before his or her first birthday. This unacceptable reality has been the impetus behind all of Nurture NJ's work, our family festivals, our Black maternal health summits, our partnerships with legislators, and our maternal and infant health strategic plan, which we unveiled just 2 weeks ago. The Nurture NJ strategic plan is the culmination of over a year of in-person and virtual meetings with our many stakeholders, including departments and agencies, health systems, physicians, doulas, community organizations, and most importantly, mothers and their families. It's designed to make transformational change in a system that has historically failed our mothers and babies of color. Its goal is to reduce our maternal mortality rate by 50% over 5 years and eliminate the racial disparities in birth outcomes. And it is part of our response to the cry for racial justice that we have heard across our nation. I've spent 3 years listening to this cry grow louder from Black mothers who have lost their babies, or very nearly their own lives, from fathers who have lost their life partners, and from countless women of color who have told tragically similar stories, stories of not being listened to or receiving the care that they needed and deserved at a time when they could not have been more vulnerable. And as we have worked to raise awareness of this crisis, I have seen New Jerseyans from every corner of our state respond, some with shock and outrage, others with sadness, but all with a determination to raise up these collective voices and demand an answer to their plea for racial justice through reproductive justice. As I said, this plan is part of our answer to that call. At its most fundamental level, the plan meets the specific needs of women in their local communities where they live, work, worship, play, and love. The recommendations range from increasing prenatal care and support for women of color to creating a groundbreaking maternal health research and innovation center. And it makes broad reforms aimed at dismantling the structures that for generations have prevented women of color from living in environments that provide the resources needed to simply be healthy. It requires all sectors, health, education, housing, business, academia, government, and more, to play an integral role in its realization. And ultimately, As I shared earlier, the success of this plan relies on our active partnership and collaboration. Just last week, I was thrilled to join with the Department of Children and Families as they released their groundbreaking Adverse Childhood Experiences Action Plan. You can be certain that these plans do not operate in silos from one another. In fact, our maternal and infant health strategic plan includes recommendations focused on trauma-informed care, as well as the implementation of the ACEs action plan. 15% of young children of color are exposed to multiple adversities before the age of 5, more than twice the rate of young white children. These disparities are due to a cycle of trauma that has resulted from the centuries of systemic racism and discrimination. Our efforts to tackle ACEs and our maternal and infant mortality disparities are inextricably linked. Healthy girls, both mentally and physically, grow to become healthy pregnant women and ultimately healthy moms. And beyond government, I have seen our network of support for New Jersey's families strengthen its ties across our entire state. In fact, I've seen firsthand the power of Jersey City's community coming together to support its moms and babies. In January of 2020, I held my most successful family festival to date at New Jersey City University in partnership with the University York Street Project, the city, and the school district. Over 110 providers ranging from the local Boys and Girls Club and Family Success Centers. Essentially all I was saying is that seeing this panel come together is just further evidence for us all that we can work together and we will work together to ensure maybe. And I would just thank all of you so much for everything you're doing, for being here today, for your ongoing partnership and your ongoing collaboration.
Thank you so much, First Lady Murphy. It's a pleasure to have you. We look forward to your continued work throughout the state. We are excited about everything that you are doing, and we appreciate your being with us today. Thank you so much.
Thank you for having me.
Absolutely. Dr. Henderson, did you want to say hello?
Yes, I would. Thank you so much. And I want to thank the First Lady for showing up, but I particularly want to thank you for making this an important part of your platform. I know that all the faculty and staff and students, not only in JCU, but in our surrounding community are very, very dedicated to this, and they work very hard at it. And I really feel like in many ways we make a good difference. But we really can't make that difference without the kind of support that the governor's office can provide. So I really appreciate that this is a priority for you. And please call us if you need some help, because I've got some crack staff, really good, who can help you out with it. They're good leaders in this. Thank you.
Thank you. Always good to see you, Dr. Henderson, and take care. And I know exactly how strong your university is, and look forward to seeing you again sometime soon in person.
You take care. So do I.
Thank you both for your remarks. At this time, I'd like to take the opportunity to thank everyone who was responsible for helping us organize this great event today. Thank you for sharing this information with your students. Thank you for sharing this on your social media platforms. And I thank all of our co-sponsors and professors and our panelists for sharing resources with us, including articles, videos, policy issues. That is in the chat. So we are sharing a shared document. Please take the opportunity to look at these resources as we continue this great work. So thank you to our co-sponsors, Women and Gender Studies, BASO, the Counseling Center, Health Sciences, the Lee Hagen Africana Studies Center, the African and African American Studies Program, the Council on Hispanic Affairs, or CHA, our nursing department, and a special thank you to our communications department with helping us to promote this event. Last but not least, I'd like to thank the staff of the Spiker Rubin Women's Center for Equity and Diversity, our program assistant, Crystal Mateo, and our wonderful student staff, Miriam Pervez, Lilybeth Mangeres, Mercedes Ruiz, and Jasmine Obali.
I don't know.
Thank you so much. So
I
now,
walk in, I see chocolate everywhere.
I'd like to ask everyone to please mute themselves. Thank you. And I'd like to continue our program with a short video to help lay the foundation for our discussion this afternoon. It's entitled Knowledge to Action, Care Equity for Black Moms, created by the Association of Women's Health, Obstetric, and Neonatal Nurses. Thank you.
I never imagined that I would be a part of statistic to be mistreated when going to the hospital to give birth. I just remember, oh my God, like, I'm gonna die. I was released from the hospital, and then the next day I was taking my daughter to her pediatrician. We went into the elevator, and the whole time I'm just thinking like something's not right. I immediately felt something, felt like it popped. It was so painful. It felt like anything that touched my skin, I was gonna burst from the inside.
I remember one incident, the nurse was doing a fundal check, and I told her, I'm like, this is painful, it hurts. She said, this is how we do it, and you have to bear it down. And I don't think that's the most appropriate way. It's what we say matters just as much as how we say it. I think it's important for nurses as well as other members of healthcare team to listen to the voices of patients and feelings be validated.
We all have this innate feeling that, yes, that exists, but I'm not a racist person. I don't treat other people that way.
We don't necessarily know that we have implicit bias. Implicit bias are stereotype perceptions that we have about things or people. It's things that we learn from our upbringing, but we all have an opportunity to change in the environments that create spaces where implicit bias is accepted.
I remember like screaming to the nurses and doctors that I was in so much pain, like I need help, something's going on, something's not right. And it just felt like they just didn't care. I was at that hospital for about 12 hours and they still hadn't found out what was going on. The nurse that I had, she kept trying to like make me do things that I literally couldn't do. I wonder if she feels like I'm just being dramatic. When you're looked at a certain way, it feels like you get a certain treatment.
The main challenge that we face in society is structural racism. Implicit bias is one of the branches that comes off of it. All play an active role, and it has to be care that validates the voice of a patient.
We really need to be so much better at paying attention to our patients. If we're not called out on it or we're not told about it, we'll never know. We'll never be able to change.
I remember being taken up to my room, and my former student was on that unit. She said, I told the other nurses on the unit that you are my program director. You're excellent, you're great. And I was like, oh, that's wonderful. It wasn't until that I felt as though the treatment that I received in the hospital was different. People thought we mattered, where prior to that, I didn't have that feeling that we mattered, which is problematic because I don't think it should matter what your educational status or your socioeconomic status is to receive proper care and attention.
I had never been through something so traumatic in my life. Being young and even wanting to have children in the future, this is something that literally makes me think not just twice, but 10 times before I even think to conceive again.
I had a desire to have more children, but based on that experience, I had a delayed process, bonded with my son in the hospital. I have reservations, and so does my husband, about planning another pregnancy anytime soon, just because of the experience we had during our first pregnancy. Hospital systems and healthcare systems have to make ongoing continuing education regarding implicit bias as mandatory, training staff members on a regular basis. It can't be something that's a one and done. It has to be something that's embedded and truly integrated within a specific hospital system or healthcare system. And it shouldn't be a shameful topic because it's something that we all have and that we learn over time. And the beauty of it is that because we learn it, we can unlearn it. It takes true commitment to self-reflect and to make necessary changes to help mitigate those biases. Engaging with diverse populations of people on a regular basis. You learn about the population and helps you better care for those populations of people. That can change the life of a child growing up without a mother.
Good afternoon, everyone. My name is Jasmine O'Valley, and my pronouns are she, her. I'm a senior here at NJCU. Currently, I'm majoring in health science, public education, and minoring in women and gender studies. I am an intern here at the Women's Center and absolutely love what I do. With that being said, I would like to introduce our moderator, Connealy. Connealy is an award-winning public radio journalist. She is currently the managing editor for Gulf States Newsroom, a collaboration between NPR and mentor stations in Alabama, Louisiana, and Mississippi. Previously, she worked at Revolt for the Centers for Investigation Reporting, KPCC, in Los Angeles, where her reporting on Black infant and maternal mortality spurred community conversations and policy change. With that being said, I would like to introduce Connealy.
Thanks so much, Jasmine. And it's great to be here today. These topics, this conversation, that video that we just watched, this is heavy stuff that we're going to be talking about for the next bit here. So I'd like to start with everyone just taking a couple deep breaths. I'm going to do it too. I'm going to do it again. Okay. So I'm Connealy, and for the past 3 years or so, as a journalist, as a reporter, I've been in this world of these very alarming statistics about Black infant and maternal health. You heard a lot of them outlined in that video that we just watched. You heard the First Lady outline how this plays out in New Jersey. I first learned about these statistics about 4 years ago. I was in LA and I was a reporter covering early childhood issues. And I went to a conference and I heard that statistic for the first time, that nationally, Black babies in the US are twice as likely as white babies to die in their first year of life. And I'd never heard that before. As a Black woman, I hadn't heard that before. I was sitting there and I was listening to a presentation and I heard that it's not just about income, it's not just about education, it's not just about things like smoking or access to prenatal care. A college-educated Black woman is still more likely to lose her baby than a white woman who didn't finish high school. And I heard in this presentation also that one of the leading causes is prematurity. Babies who are born too early, too small, they don't make it. And when I heard that, that really jumped out to me because I realized that my own family was part of this statistic. I have a sister who lost 2 babies who were born premature. And I have another sister who had a baby early and thankfully he made it. And he's going to be 14 this month, which is wild to me. He's doing great. But there are so many babies who do not make it. And I immediately called my sisters after hearing this presentation. And I said, have you guys ever heard of this as a national statistic? Did you realize that your personal experience is wrapped up in this bigger trend? And my sister Nicole said something that really stuck with me. She said, I'm not sure that we are aware that this is an issue beyond just our bodies. And I think that that's true for so many women. And one thing that I like to really make clear is that this is not new. There's been a lot of attention around maternal deaths. That's what we mean when we say maternal mortality, maternal deaths, and infant mortality. Infant mortality is when a baby dies in its first year of life. But these statistics have been true for a really long time, especially when it comes to infant mortality. In some of the reporting that I did, I found this transcript of a 1984 congressional hearing. 1984, Congress convened for a session called Infant Mortality Rates, Failure to Close the Black-White Gap. And there was testimony from all over the country, and this was in 1984. So then that statistic, that gap, that 2 to 1 is still there. Fewer babies die today, but that gap is still there. So in our conversation today, we're going to be talking about some of the reasons that it persists. And one of the things that I think that really just needs to be clear is that it's not race, it's about racism. It's about the lived experience of being Black women. This is also true for Latino women, for Native American women. It's about the lived experience in this country. And we're going to get into a lot more of that in our conversation today. I start with kind of that personal story because I think that sometimes we hear these statistics, we can become a little bit numb to them, and they just become kind of facts of life and facts of the United States. And it shouldn't be that way. These are things that really affect people, like those stories you heard in that video. These are things that affect real people. And a lot of people may not even realize that they're part of this national statistic. So I would like to get into a conversation with our great panel today. We have very accomplished people that we're going to be speaking with, and I'm going to give you a brief bio of each person, and you're going to see a longer bio of all their accomplishments in the chat. So our first panelist is Dr. Shelby Pitts. She's an instructor and interim program director at Rutgers. She teaches obstetrics and graduate and undergraduate programs. And she's also a board certified women's health advanced practice nurse. And she specializes in women's health and maternal mortality and morbidity. Dr. Pitts, welcome. Thank you for being here.
Thank you for having me. Can you hear me okay?
Yes.
Okay.
And I want to start with asking you, how did you come to do the work that you do?
So I will start by saying, good afternoon, and thank you so much for inviting me to this event. I think it's absolutely wonderful that we're having this conversation. I will also say, as I'm watching, that was actually the first time that I'm seeing that video, and that video actually highlights my personal experience. I unfortunately had a stillborn in my early 20s, and it just, as the young women were speaking about their own experiences, I started thinking about, wow, I haven't sat and really thought about it in so long, since then. But my personal experience has been, unfortunately, I am one of those statistics. I had a baby that was born at 23 weeks. And I will say that my providers were not listening, which is why part of my own personal professional journey has been to actually because it's so personal for me, that women have a right, to a healthy pregnancy. And not only that, but just understanding the magnitude of what it looks like when they are unheard and when they're not being taken seriously in terms of things that they're experiencing, feelings, because sometimes you just can't put it into words necessarily. So even in my own practice, because I'm an APN, I have learned to listen because it was me. And every time I hear a story about a woman who unfortunately, she's had bad outcomes or the baby's had bad outcomes, I always think this could have been my patient. So when I first got into nursing, I never thought I would actually be where I am. That's the wonderful thing about nursing. You can be anything and still be a nurse. But my maternal child health journey has really been unique in that given this platform essentially, and through that actually have learned from my own personal experiences, which I really feel has helped me develop into a much better provider. And then being African American myself and understanding some of what that looks like, just from a day-to-day, some of what that experience means, and especially when we're talking about healthcare. And what what some of the barriers and the disparities are for us. So that's been my my personal and professional experience and background.
Thank you for sharing that. And
Thank you.
So sorry for your loss. I'm sorry that you have that personal connection, as so many people who do this work have that personal connection.
Yeah.
But thank you for sharing that.
Thank you.
Our next panelist that I want to bring into the conversation is Dr. Michelle Griffith, aka Dr. G. She's the medical director for the Premise Health in Charlotte, North Carolina. The Health and Wellness Center is a primary care practice with a focus on preventative care and lifestyle management. She's been practicing for 30 years and also does a lot of work in telemedicine. Dr. G, thank you for being here. Uh-oh, you're on mute. As we say in the Zoom world we're in now.
Right, exactly. I needed the sign, you're on mute, but that's okay. Thank you. But I'd like to first and foremost thank the Women's Center for inviting me to be a part of this significant discussion. I've been practicing integrative and internal medicine for over 20 years, and certainly really close to 30 years. And certainly a significant part of my practice, my patients are African-American women. So this is an ongoing, pervasive issue. Unfortunately, it is not the exception, it is the rule. It is pervasive not only with issues of maternal health, but also healthcare in general. So I got intimately involved in advocating for improving these healthcare disparities back in 2018 when I was introduced to a couple, Tamika and Brandon Isaac, who founded Jace's Journey. Jace's Journey, this is in Charlotte, North Carolina area. Jace is actually their son who was lost during childbirth, and they took their tragedy and pain and used it as a catalyst to form this nonprofit to address the issue we're discussing today. A professional couple, it was their first child, and unfortunately, it was actually highlighted in the Charlotte area because it was such a stark example of what we're discussing today. Tamika, unfortunately, a month prior to delivery, actually was rushed to the emergency room. She was hemorrhaging. Her liver was bleeding, and she actually, they lost their child. And unfortunately, she was hospitalized for 40 days, required 7 surgeries. They really considered it a miracle that she even survived. She had preeclampsia and HELP syndrome, which you can certainly look up. But in really investigating what transpired, unfortunately, she did not have a urine checked for 5 visits, which is standard of care. She later discussed feelings of bias. One of the providers, when they walked in, once said, "Oh, is that your baby daddy?" And she said, "This is my husband." So there are all these other examples. So they took that and formed Jace's Journey. It has many different facets. They collaborate with other organizations in the Charlotte area that are looking to decrease the disparities. Large part of the organization is involved in political activism. We founded a Jace's Journey 5K to raise money back in 2018. So we've been doing it every year. This year was done virtually with a small group in person, raised significant amount of money. And that money actually went towards a partnership with Johnson C. Smith, which is the HBCU in the Charlotte area that has a lactation certification program. And there's also doula certification organizations in the Charlotte area, and scholarships were given for women to be trained. And also money was given to provide families with doulas for a certain duration of time, both prenatal, at delivery, and up to a year after delivery. So there are many different ways that this couple, I always say the power of one, this is the power of two, and there is just a ripple effect just from their advocacy and and I'm just so proud to be a part of that effort. So that's primarily how I got involved in this issue. I'm also on the executive board of the International Society for Telehealth and E-Medicine, e-health, which is based in Basel, Switzerland. And that's an organization that is basically an umbrella organization over 75 countries around the world. We are an NGO, a non-governmental organizational partner with the World Health Organization, and we have a very large component, very active women's working group. And part of that, we have a very active nursing and midwifery group. As a matter of fact, this last year, the year of 2020, was a year of midwives and nurses per the World Health Organization. So we had a lot going on surrounding that. But we've actually, that particular working group, one of the founders created an app that has been quite successful in rural parts in around the world in improving women who are pregnant, improving their access to care, their education with respect to signs and symptoms, what to look for. And they're actually now seeing data that shows that the app is actually successful, and they're now expanding it. So we're hoping to utilize that technology in Charlotte and pilot that with some of the organizations that we're working with as well. So.
Wow. Wow, thank you for sharing all of that important work, and especially the work of that couple. And just as you were talking, there are just so many similarities when we talk about HELP syndrome and preeclampsia. There's so many eerie similarities in these stories that I've heard over the years as in my reporting, but also just from so many different sources. I think that's one of the heartbreaking parts of this, is that, we know what happens. We know what happens, and it keeps happening. And as we talk through, so far, and as we continue this conversation, systemic racism is something that comes up a lot. And we want to just play a short video now to clearly define what that is.
Oh, hey, I didn't see you there. If you're like most Americans, you probably say to yourself all the time, systemic racism, is that really a thing? Well, did you know that even though America's infant mortality rates have gone way down in the last 50 years, Black babies are still about 2.5 times more likely to die before reaching their first birthday? Did you know that Black mothers are 3 times more likely to die during childbirth? That Black and Hispanic women are more than twice as likely not to receive proper prenatal care? And Native American mothers are 3 times less likely to receive proper care? Did you know that? Do you know what that's called? That's called systemic racism. And yes, it's really a thing.
So it definitely is a thing, and it's something that our next panelist researches a lot in terms of a focus on maternal mortality. So I'm going to bring her in now. Dr. Christine Morton is a research sociologist at Stanford University in California. She researches maternal mortality and morbidity and collaborates with clinical and public health stakeholders in translating those findings into quality toolkits. She investigates the drivers of those disparities in neonatal outcomes with the goal of identifying potential interventions in care. And she's also the author of Birth Ambassadors, Doulas, and the Reemergence of Woman-Supported Childbirth in America. Dr. Morton, thanks so much for being here.
Well, thank you for having me, and I echo the other presenters too. It's a real honor to be here today to talk about a very sobering topic. I've been working in this field since 2008, when I was recruited to Stanford to come and work in this, with this project that this small organization was doing with the State Department of Health. The California State Department of Health recognized in 2005 that maternal mortality rates were going up, and that the Black-white disparity was, not going down, was also very concerning. And so they tapped into this group at Stanford who understood how to change big systems, healthcare practices, called quality improvement. And the founders of the organization I'm with at Stanford, the California Maternal Quality Care Collaborative, the founders went around the state, let doctors know, let nurses, midwives, key stakeholders know this is what's happening, and got a bunch of very dedicated, passionate, well-regarded experts from all over the state. And it's echoing what the First Lady was saying earlier. These folks recognize that to address the issues, we really had to take a multifaceted approach. When they started looking at maternal deaths, they recognized that hemorrhage right away was a very preventable cause of death, and that there was no good reason women should be dying from this, in California in the mid 2000s. And so work began right away to assess, what over time, I'll just go to the punch point, the two most preventable causes of maternal death are hemorrhage and hypertension. And these are extremely preventable, but it turned out we've discovered these 3 Ds: denial, delay, and discounting. So there's, denial, not really seeing that this is an issue, these vital signs, these signs that even women are telling the providers their symptoms are not being listened to. That's the discounting, and therefore there's a delay in responding. And then there's the tragic outcomes that we saw all too often when we reviewed these cases of maternal death. And, I came into this, I was coming from a background in studying people who were interested in promoting less intervention birth, right? The doulas, the childbirth educators. I had worked in that community, and I was brought into Stanford to work with these clinicians and public health folks and epidemiologists because I brought this other perspective, this other lens. I'm a sociologist. It's kind of like nursing. We can do anything. But I was interested in everybody's experience throughout this, certainly the woman, her family, and certainly I was learning to understand how passionate these clinicians were about recognizing, facing up to the problems and working to change them. And I started collecting and interviewing women who had those tragic experiences with a pregnancy complication, and brought that sort of patient woman-centered experience into these toolkits that we created. So for example, to prevent hemorrhage, it turns out you actually need to quantify how much blood the woman is losing throughout the course of her stay in the hospital. And people were estimating it, and they were like discounting it. And by the time, then it was an issue of, well, do they know her blood type? And how do we communicate with the blood bank at the hospital? Like all these systems level issues, all these provider level issues. And once those lessons came out from these deaths, doctors stood up and listened. And they, sort of began looking at this. And the other piece I'll just say is that we've learned that maternal mortality is not a unified category. So there are these clinical deaths like hemorrhage or hypertension or blood clots that happen in the first, week or first 6 weeks after pregnancy. But then you have deaths that occur very late, like cardiovascular deaths. And those are deaths that Black women especially are more vulnerable to. The rates of death due to cardiovascular disease are 5 or 6 times the rate in Black women than they are in non-Black women. And because those deaths occur, after that 6-week point, they continue to live, but at great cost to themselves, and those deaths are often missed or not recognized. And so, there's different strategies that we have to use to address different kinds of death. I won't go into, the tragic cases of maternal deaths by suicide, drug overdose, or homicide, but we are seeing, different issues in those kinds of cases, and all of it, I think, is resting on this foundation, as we've said many times here, of systemic racism. And I would also say systemic, sexism, not listening to women. And I think we heard, when the slides presented the stories of celebrities, or, like Beyonce or Serena Williams, where even their privilege and power and knowledge of their own body, was not enough to overcome that double burden of racism and sexism, where we're not going to, we're not going to listen to you. And so I was doing all this, academically in my head, very passionate about women's experience and advocating for that. And then a few years ago, I found out that my cousin died 6 months after giving birth to her second child. And it was a cardiovascular case. And I had just published a paper on, how women talked about being diagnosed with cardiovascular disease in pregnancy or postpartum based on website discussions. And then I'm like, oh my God, this happened in my own family. And it's confusing, it's heartbreaking. People don't really know why it's happening, and it's complicated, but there is a lot that we can do, as Dr. G was saying, locally and then nationally, and I can talk about later, the ways that we can get involved with many efforts going on now to address this.
Wow. That's why I had everyone take a deep breath at the beginning.
Yeah, I appreciate that. I learned that, I had to do that and imposed it on the clinicians, the doctors, and everybody. And then in the end, they realized they need it too. I mean, this is hard on everybody involved.
It is. And thank you all to our panel for sharing how, that intersection between the personal and professional, because once again, I think that just makes it more real for people. These are not just statistics. This happens to people that this happens, to people who it may have happened, and we don't talk about these things. These are things that are really hard to talk about. And we've talked about mortality, but morbidity, another one of these words that we've heard a lot in the last year, comorbidities and things. But that, in terms of maternal morbidity, that's just women who make it, these near misses, but have, sometimes debilitating effects for the rest of their lives. And when we talk about data issues, there's a lot of stuff missing. There's so many stories that we don't know there. Mm-hmm. You've all touched a little bit on the solutions part of this, but I want to take us there now, and we'll start taking some of the questions that have been submitted prior to this. But since our main audience for this conversation today is students, I want to kind of shift to how can students, many of whom are parents or hope to be parents, advocate for themselves. So we've laid out these statistics, we've laid out this really horrifying information about the state of maternal and infant health in our country. What can we do with it? What do you want people to know about how to advocate for themselves? Dr. Pitts, I'll give that to you first. You're on mute.
Okay, I'm unmuted now, sorry. So a couple things that, and again, just speaking as a APN, one of the things that I don't think we do enough of is preconception counseling. That is when a woman presents prior to becoming pregnant with the intention of just saying, I'm planning to have a baby in the next year. What are some of the things that I can do, now to put myself in, a better situation for when I am pregnant? Understanding that research and, and everything does support the earlier women do this, and I mean teenage years, so the habits, the exercise, the diet, things like that play a huge part later, obviously. Having, certain access to care and insurance and financial stability and, all those things play a part when you're talking about pregnancy, because it's not just the physical piece of it, like once she becomes pregnant, but being able to sustain that pregnancy. And then the support around her. We do keep track of, the CDC and all the other national organizations keeps track of data that looks at all those variables, in terms of what, impacts a woman's outcome and how healthy she is during a pregnancy. Because mommy's being healthy, increases the chances of baby being healthy, and so, which is really what we're talking about here. So in terms of, and I just shared my own personal experience. I was actually a senior, getting ready to graduate and, start life and everything when that happened. And I think that because, younger women don't tend to think about those things, but that's what's really important. And the message that we probably need to send more often is what can you do to help prepare for when you are ready to have a family. So whether that's in your 20s or 30s, because a lot of my patients, wait till they are married and their careers are established and things like that, but they start doing things ahead of time. So having those conversations with your providers is really important. And as much as possible that, that you can control, you try to control and just advocate for yourself and develop those habits early on, so that when you do find out and you're actually pregnant, that you can be in the best possible situation to have good outcomes.
Thank you. Dr. Griffith, anything that you want to add to that?
Yes, I'll add that, I am quite big on prevention, and I think this country does not focus enough attention on the obesity epidemic in our country. It is a modifiable factor, and it happens to be a factor that plays a significant role in increasing your risk for preterm labor, for hypertension, for preeclampsia, for gestational diabetes or diabetes developed during pregnancy. And certainly African American women, we happen to have the highest rate of obesity when you break down all the different groups in this country. So for me, it is very important. I have that discussion whether a patient is coming in for sinusitis or whether they're coming in for an annual physical exam. I discuss lifestyle. I think from in your 20s, college student, you're thinking, gosh, how do I advocate for myself? It really is establishing those healthy behaviors at where you are in that young age, because as you get older, it gets a lot harder to lose the weight. But if you start with educating yourself, and you really have to be intentional about it, because this society is an obesogenic culture, an obesogenic society, the convenience foods, the unhealthy foods. So you really have to be intentional about nutrition, avoiding processed foods as much as possible, eating whole foods, fruits, vegetables, minimizing starchy carbs and things of that nature. Exercise, of course, is very important. Sleep is very important. We ignore that, but sleep plays a significant role in helping you to maintain a healthy weight. So I do a lot of counseling regarding healthy lifestyle behavior, so that it becomes your lifestyle, not something that becomes drudgery later because you're just not accustomed to it. You don't like to do it. And so I would say that, number one. And secondly, I would say make sure you educate yourself about, when you do become pregnant, about what type of care, what to expect when you are going to your doctor's visits, because no one can advocate for you like you can advocate for you. So if there are things that are not being done, you can certainly ask those questions. And if you don't feel the connection, because connection with your provider is very important. And if you don't have that connection, you have the power to seek another provider. Never feel that, you have to, if you have insurance or if you have some other options, you have to stay with a particular person. And I would say that's what I would add to Dr. Pitts's very well-received and great pearls of information. So thank you.
Yeah. So there's the kind of personal and getting the vessel ready. And then there's kind of the preparation for your there's only so much you can do for yourself, for the individual. You're still entering into these systems. So kind of being educated about how to respond and advocate for yourself when you do enter the systems. Dr. Morton, a question for you in terms of prevention, kind of on that policy level, because you do this work to make these toolkits and to really like systematize some of the things that can improve outcomes. We have a new administration in the White House now. And as I said before, this is not a new problem. This is not anything that was created during any one administration, and it will take a long time to fix. But what needs to happen on the federal level in terms of policy, and what are some of the things that are happening?
Yeah, thanks for that. I will just address briefly the education part. Like, I appreciate what you said, that individuals need to educate themselves, but they are entering this big system that they have to understand. And I think there's better and worse sources of information, especially in the birth zone, about, that are more, and there's a lot of great websites coming up about these kinds of things. There's Lamaze International, which is a very well-respected group. There's the guide that was recently developed by 2 Black women, anti-racist prenatal postnatal care practitioners. I saw that was on your reference list. I've met with those folks. They're out here in California. There's Childbirth Connection. There's Black Women's Health Imperative, Black Women Birthing Justice, Black Mamas Matter. There's all these organizations that I think are much more credible for especially Black women to get information about how they can best interact in the system, because it's not always easy. And it helps to have that support, structural support behind you. On the national level, I will say that just a few days ago, the Momnibus legislation was introduced in Congress. And I think all those efforts like that have been really important. There's been legislation, there was a legislation a couple years ago that supported states funding and running their own maternal mortality reviews, because the states can get information about the maternal death that is not available to the national level. And, not all doctors are going to, doctors in New Jersey might say, well, that stuff came out of California. Our women are different than those women, right? And so having those local reviews and engaging local, experts and community members in those reviews is really important, because that's where, the recognitions come from. That's where people see these patterns over and over again, and are able to see that validity in that. And to that point, I've been monitoring media on this issue for a long time. And up until 2017, when ProPublica came out with the Lost Mothers story, they combined with NPR to get that news out there. The dominant narrative coming from clinicians who were quoted in the news was, well, women are dying because they enter pregnancy at older ages. They have more comorbidities. They're of heavier weight, right? And what they're also not saying is that more and more of them are having their care paid for by public funding. States cover 50% of births in the country. And, there's more Black and brown people having babies, right? So the implication was the problems were residing in the women's bodies. They were older, they were fatter, they were sicker, they were poorer. And since the news media came out with the stories of all these women who are being lost to this preventable cause, and then becoming aware of what we're doing in California, what we're doing nationally, to recognize that these are problems at the hospital level. There's no good reason why New York City, for example, has a hemorrhage rate that for Black moms are 12 times more likely to die of hemorrhage. That's systemic racism, right? And so it's not the onus of responsibility is not solely located in the woman's body or her comorbidities. If she's obese, she certainly has a greater risk for blood clots and CVDs. We saw that. But an obese woman can die from a hemorrhage that was poorly managed, and her obesity had nothing to do with that. And so it's really, you know, this information coming from California. We provide 1 out of every 8 citizens to the country. The power of numbers here became very convincing, even to clinicians across the state that have fewer numbers of deaths. And so just the prevention level is so multifaceted, right? And we have to bring public health into it, as well as the clinical world. And we've done a lot of good work to educate Congress. I was going to look up how many congressional briefings have happened, you know, in the last 5 years. You mentioned one from 1984, but I would like to see how many have been done in the last 5 years. And I believe that has made a huge difference in the awareness that we're seeing on the national level and also on the state level. So I'll stop there for now because I could go on.
Yeah, certainly. I think just from my own, you know, reporting on this, there has been more attention to it as people start to share their personal stories, as people, you know, like you mentioned earlier, Beyonce, Serena Williams, those stories show, oh, this isn't just some other, this isn't just, you know, some women who aren't doing whatever. Like this could happen, this really could happen to anyone. And this really, I think that their stories really help to move the needle, along with having more, you know, Black women leaders like Kamala Harris, who championed these things in the Senate.
Right. It's yeah. And because it's systemic, you know, it's when these people with voices fall through the cracks that they're able to amplify, like Charles Johnson, who lost his wife Kira at Cedars-Sinai, you know, a renowned hospital in LA. When these folks, you know, look and investigate, they find these systemic problems that are just, it doesn't matter that, you know, she's healthy and bright and speaks 5 languages and was going to be a doctor. You know, it's so tragic. And so it's the systemic solutions that are really important at this time. And I'm very grateful more people are realizing it. The media narrative has changed a lot. It's racism, not race. Right. It's all these other things. Yeah.
Well, thank you so much for answering those questions. I want to throw in some now that we got some submitted questions that we got, and we are kind of coming closer to the end. So just keep that in mind. We want to get to a few different questions before we wrap. One question that I have is, you know, we've heard a lot about, you know, the kind of the failures of hospital systems and the racism within implicit, whether it's implicit bias, you know, things that people can encounter in the healthcare system. Someone asks, why not promote more doula and midwifery training? Who wants to take that on? Or maybe we can talk, since that is one of the solutions. So many of these things are interconnected. Who can talk about what's going on in terms of midwifery and doulas?
Well, I could take the first stab at that if that's okay. Yeah, I've been researching.
Maybe just say what a doula is in case someone.
Right. So a doula is a person who is trained to support birthing people and their partners, their support group, with informational support. So they're good sources of evidence-based information on all things related to birth, pregnancy, and postpartum. Emotional support. This is a piece of the picture that doulas identified as a big gap in hospital-based care, that the focus is on the machines and the drugs and the next patient, and there's not a sole focus on what does this woman need emotionally, what does her family need here, and physical support, because labor, whether you have an epidural or not, it's a marathon, it's a physical event, and the doula is there to help the woman and her family stay in good shape physically as they go through this process, and then provide, some basic postpartum breastfeeding support through the end. And so they're not clinicians. That's important. They're not medical people. They don't diagnose or treat, disease or conditions, and they're not supposed to give medical advice. Their big role is to place that woman at the center of her birth. Midwives are trained clinicians. There's many different kinds of midwives, and certified nurse midwives are integrated into hospitals. The community midwives, not so much, different states, et cetera. The thing about doulas and midwives is that as great as they are, midwives attend about 10% of births in the country, and doulas between 5 and 7%. Right now, they're not scalable, but the great thing about being a doula is it's easy to become a doula. It's a 4-day workshop. You can learn a lot, and you can take that information in many parts of your life, not just to be a professional doula, right? Grandparents take doula trainings to help their mothers, relatives take doula trainings so that they know how to best support their family members. Childbirth education is dropping by the wayside, and more people need to do that. But so, I think we need to also pay attention to the labor and delivery nurses who are on the front lines. They're at every single birth. They're at every postpartum. They're in the NICU. And they also need support and information. Many nurses coming out of nursing school now aren't really trained about nursing. And so whatever they learn about nursing, and Dr. Pitts can certainly speak to this better than I, they learn on the job. And what is the culture of nursing at that hospital, right? And physicians too, they're not all the same, and obstetricians are recognizing that, at least doulas are a good help, a good strategy. I think we need to empower everybody in the arena and not rely on doulas per se, which are, they're underpaid, they're overworked, they don't, it's like they almost have like a symbolic authority, but when they're in the setting and the work they do, they're not really affecting how many cesarean rates that hospital does or that provider does. And so, they're essential, but they're part of the bigger system that has to also be supported.
Right. One of the reasons that we pay attention to infant mortality rates of a country in general is because it's just one indicator of the health of a society overall. So many of these things are interconnected. Like, you can't just solve it in the hospital. You can't just solve it at home. It's connected to so many big system things. Dr. Pitts, did you want to add anything to that?
Yes, I actually wanted to thank you, Dr. Morton, because you brought up a lot of, very, very good points. But in terms of the doulas, that's definitely a piece of it. The other part, and this is something that, I even started doing in my own practice, is looking at the provider. And I'm so glad you talked about the L&D nurses and the postpartum nurses and the nursery nurses, because their level of training, their level of education is extremely important. And as we all know, once we graduate school, learning does not stop, because healthcare is constantly changing. So the evidence changes, the protocols changes, the guidelines changes. And as a nurse, by trade, and then as, an advanced practice nurse, I am ultimately responsible for that information, as many of us are, like once we get into, our practice. So one of the things that I also think is imperative, along with our medical team, is that collaboration, because it really does take a village. It takes everybody to be a part of, of the solution. And so things like some of the ongoing education from a nursing perspective that I have actually been a part of as well, is doing things like simulation with nurses. And that means that we're acting out an actual scenario with, and implementing and putting those guidelines and protocols in place, like what Dr. Morton was highlighting with the California Maternal Quality Collaborative. And those toolkits, because I've actually used them in my own simulation scenarios. They're excellent resources that we've used in our practice. So from, the faculty standpoint with the nursing students, and then also from the bedside standpoint with the nurses themselves, and implementing, the simulation scenario so that they know what to identify when these women present. We know how to, we have the tools readily available for these emergency cases, whether it's, preeclampsia, high blood pressure, or postpartum hemorrhage scenario. So absolutely, that plays an important part as well.
Just in the interest of time, I want to move to a different question for you, Dr. G. Someone asked about how the pandemic is affecting all of this. With so many things, we've seen so many gaps widen, so many issues exacerbated during the pandemic. Can you talk a little bit about how birthing has been impacted, in these statistics? There's a lot of it. Of course, we don't know statistic-wise exactly what's happened, but some of the concerns that have come up around maternal mortality during the pandemic.
Right. And I think Dr. Pitts would probably be more appropriate with respect to answering that question regarding births. For me, I would say in general, certainly people have been very reticent, and certainly initially at the start of the pandemic, we did not have the necessary protocols in place, COVID protocols in place. We actually had to establish those protocols. So many people delayed care, and that certainly the pandemic is essentially just, if anything, probably exacerbated the underlying problems that we were already dealing with, just as it's exacerbated everything else, including the disparities in health statistics in general. So, Dr. Pitts, would you like to take that specifically?
Sure. In terms of COVID, to Dr. G's point, is we are still learning, right? But yes, in terms of protocols and guidelines, I think the research is ongoing. I don't think we have definitive numbers in terms of what this has actually impacted. We recently were looking at some of the articles that were just published about COVID-related illnesses and moms that are positive, and what does this mean for the unborn baby. And depending on when mom became positive, if she was positive in the early part of her pregnancy versus later, okay, that all of that research is still ongoing. But in terms of protocols and guidelines, it is ever changing. And in our institution, we have changed practice in terms of what our testing guidelines are. So we test every mom that comes in. Our PPE guidelines have changed in terms of protection for the staff as well as the patients. They're only allowed one support person. Governor Murphy actually put protocols in place for New Jersey in terms of what that support looks like. So doulas are part of that equation as well. So the moms can have a doula and their support person. So during this, pandemic, and still be within, the safety parameters of that. But I think it's a hard question to answer at this point, just because of where we are. And as long as, the good thing is that we're getting more information. But the other piece to that is that it's still a lot of questions behind it.
Yes. And I'm seeing a lot of comments in the chat that people wish this could go on for longer. There's so much, we are kind of just scratching the surface in our conversation today, and there's so much to this issue. We've given people a lot of information. I want to see if each of you could just answer this quickly, just in a sentence or two. What gives you hope right now? These are not new problems. These are not new statistics. What's one thing in this space that gives you hope? Just really quickly. Dr. Morton, I want to start with you.
Yes, what gives me hope is that, you know, a lot of the clinicians I've worked with from the beginning have recognized this as a problem, but now they're actually saying things like systemic racism and institutional racism, and recognizing that racism and not race is the issue, and the voices and leadership of Black women in this area have just been amazing. And I also want to give a shout out to Black midwives who have created like community hubs for Black people. There's Hakima Payne in Kansas City, Jenny Joseph in Florida. Just look up Black midwives. There's just a whole lot of local stuff happening, and that gives me a lot of hope.
Thank you. Dr. Griffith?
I would say the awareness, particularly amongst African American women, because I know that when African American women are aware, we are an action-oriented group of people, and we do amazing things. And I just see the groundswell over the last 2 years, whether it's a coalition of 100 Black women or Representative McGrath introducing that Momnibus legislation, or Power Rising annual conference started by Bishop Leah Daughtry, where thousands of Black women come together and address so many different issues. So I think that's what gets me really excited, because that, in addition to what Dr. Morton says, seeing corporations and institutions actually utilizing and acknowledging the existence of racism. I've seen a whole lot of diversity officers being hired to address cultural biases and disparities, racial inequities in the corporate setting. So those types of things that I'm seeing more frequently now make me very hopeful, very hopeful.
Great. Thank you. Dr. Pitts? We'll give you the last word. What's giving you hope?
Oh, I'm sorry, I was not muted. Platforms like this, absolutely, bringing awareness, starting the conversations, and and initiatives like our First Lady just talked about, in terms of the federal, whenever you have those initiatives that are starting, then absolutely you're heading in the right direction. So all of those things give me hope. In that at some point we will definitely make a difference with these outcomes.
Well, thank you so much for adding all of your voices. Thank you for our great panel, Dr. Shelby Pitts, Dr. Michelle Griffith, and Dr. Christine Morton. As we said, we're just sort of scratching the surface, but it's great to get this conversation started in this space. And also, I would encourage people to check out all of the resources, and so they can continue to learn more and share it with others. I'm now going to pass things over to Summer Dawn, who is going to introduce a special performance that we have.
Thank you so much, everyone, for sharing all of your wisdom and knowledge and your hope just now, especially for this very important topic. So I'm Summer Dawn. I am the founder and director of In Full Color. We're an organization based in Jersey City, New Jersey, that empowers women of color through education and the arts. And we're proud to bring a performance here today by the amazing Audrey Martels. It's a Big Belly Box by Tueri T. S. Ganges. Audrey, take it away.
Okay, thank you. Hello, everybody. Pregnancy. Oh, the glow, the beautiful baby bump. Everyone caters to the mom to be, right? Well, maybe not if you're Black. When I was 8 months pregnant with my son, I had to go to one of those big box office supply stores to get a printer before the sale was over. Home office printers weren't so compact and lightweight back then, so, I just waddled around the store until I found the item I wanted, by myself, I might add. I waited for one of the many clerks to come by and assist me, but it didn't happen. And let me just say, the place was practically empty that day. And so No one was exactly busy with other customers. Finally, I edged the box off the shelf until it basically fell into my shopping cart, and I waddled my way to the register. The cashier was talking to two white male employees, and then there was me with a big old box and a big old belly. Have you ever worked in customer service job before? I mean, most of us have at one time or another. Keep the customers happy and offer assistance always, major parts of the job description, right? What about gentlemen who hold doors for ladies and offer to carry something heavy to their cars? Now, I know men still do this, and that men did this back when I was preggo, but when you're Black and pregnant, it all seems to go out the window. Not a single one of those men with their name tags and creased slacks acknowledged that I was even a customer, let alone a pregnant woman who had to get a heavy box to her car. I struggled alone, in the dark, awkward box and awkward belly. Call it hormones if you want, but I cried all the way home. And what if I pulled something, I thought, wiping away tears? What if my water broke? I'd have to drive myself to the hospital, I guess. I thought about white girls I'd gone to school with who could cry their way out of speeding tickets, but I could get one on the corner of my street while pleading that I was about to pee myself. I'd be happy to come out for my ticket after I go to the bathroom, officer, but no. Squeezed knees and no relief. I had to pay $75. Then I was miserable when my husband's sister took the bed and I had to sleep on the carpeted floor back when their mother moved into a new house. Even Black women treat pregnant Black women like sturdy workhorses. Of course, I was fine. The only things that hurt were my back and my pride. I do come from the same race of women who were forced to work the fields right up until they gave birth. And they deliver their babies, tie them to their chests, and go back to picking cotton or tobacco. These women had to take their breasts out of their newborn's mouth to go nurse the master's wife's baby at all hours of the day and night. But that doesn't mean we should have to stand on the bus or train while able-bodied people sit comfortably. And damn, if I was a skinny white girl, those clerks would have helped put the box in the car. Don't assume that just because we have dark skin and big bellies that we don't have husbands and that our kids don't have the same father. Don't assume that we can work double shifts, that we can lift heavy bags and boxes, that we can stand for hours, that we can walk for miles, that we shouldn't be given the same courtesy as any white woman with the pregnancy glow and beautiful baby bump. It's the miracle of life for us too. Why shouldn't we enjoy it? Thank you.
Thank you so much, Audrey. Thank you, Summer Dawn, for participating and having In Full Color be a part of this program today. That was absolutely phenomenal. Thank you. And that's where we will leave it today. We have heard so much. We have learned so much. And now we are challenged to move forward with our work, with our advocacy, with passing along this critical information. We've shared resources with you all. A number of things came through the chat during the program. Thank you for all of that. Pretty soon, in the next couple of days, we will add the information that was just shared to the shared document. We would really appreciate it if you could take the time to fill out our evaluation. We're always trying to better our work and our programming, so your feedback is very much appreciated. So we are just skimming the surface today as it relates to this critical issue. We hope to have more conversation. In the meantime, I'd like I would like to thank all of our panelists today, Dr. Griffith, Dr. Pitts, Dr. Morton, and thank you so much to Connealy for moderating today. You hosted so well, and you led the discussion in a very powerful way. So thank you, thank you, thank you. That's all I have to say. And enjoy the rest of your day. Happy Black History Month. Please continue to support the programming at the Women's Center. We have our Here We Are Again event next week at 2 o'clock. Please follow us on social media at NJCU Women's Center, and we hope that you enjoy the rest of your day. Thank you so much. Bye-bye.